Okay, I want to thank everyone for joining us in person and on the webinar. For today's Grand Rounds, we are pleased to welcome Dr. Alex Fay, a UCSF alumnus and Associate Professor of Neurology. A Bay Area native, Dr. Fay also holds a doctorate in biophysics. He combines this deep understanding of molecular mechanisms with clinical expertise in neuromuscular disorders, including muscular dystrophy and spinal muscular atrophy. His research is dedicated to bringing targeted therapeutics to children with rare neurogenetic diseases. Today, he will show us how established strategies for treating autoimmune disease are providing the blueprint for managing the complications of modern gene therapy. Please join me in welcoming Dr. Alex Fay.
Right. Hi, everyone. Thanks so much for the opportunity to speak with you today. I work on both sides of the Bay, and if you've worked with me at Mission Bay, it's usually for one of my complicated patients with myasthenia gravis, and if you've worked with me in Oakland, it's probably for one of our complex gene therapy patients. And I'm so grateful to all the PICU and hospitalists, attendings, residents, fellows, subspecialty consultants who have helped manage these patients over the years. And I'm hoping that this presentation kind of sheds some light on why we're doing some of the things we're doing and gives you a little more insight and investment into caring for these patients. But really, this talk is dedicated to all of you for collaborating on what's often really challenging management for these groups of patients. And so here are my disclosures. And what I want to get to today, I'm going to be covering two broad areas, myasthenia gravis and gene therapy. And I'm going to focus really in the first part on the synergy between myasthenia gravis and autoinflammatory syndromes, which I will describe in some more detail, and then discuss the management of patients with refractory myasthenia. And I'm going to kind of switch gears, but not completely, to gene therapy for neurogenetic diseases, focusing on some of the new developments in neuromuscular disorders, but also bringing in some data from one of our clinical trials of a CNS disease, and want to dig into some of the toxicities of gene therapies and what we're learning over time and hoping to get better at managing and avoiding in the future. So to kick off the first part of the talk, the patient who really set me off on this journey of myasthenia gravis and autoinflammatory syndromes is a 7-year-old I met many years ago who had this long history of rashes and joint pains, would get these really red, angry-looking ears, typical of relapsing polychondritis, and had been followed by Alice Chan in immunology for quite a while. And when I met her, she'd been having weakness in her legs for about the past month and a half. And there was some interesting features of the weakness, particularly that it seemed worse in the day. So she would wake up feeling fairly okay. And then as the day went on, it would be harder to do things like walk upstairs and walk a few blocks. When I examined her, I found that the weakness was not just confined to her legs, but she had some weakness in her eye closure muscles, her neck flexion muscles, her shoulder girdle, her fingers, as well as the hip girdle. And the rest of her exam was pretty unremarkable, normal sensation and reflexes. And so whenever I hear about a patient having fatigable weakness, meaning the more they use a muscle, the weaker it gets, or weakness, double vision, droopy eyelids later in the day, it always makes me think about the neuromuscular junction as a localization, really more than any other part of the peripheral or central nervous system. And so honing in on the neuromuscular junction, this is where the motor neurons meet the muscles. And the motor neurons release acetylcholine, which activates the action potentials in the muscles and ultimately leads to muscle contraction. And so I was immediately thinking neuromuscular junction for this patient. But there are several different kinds of neuromuscular junction disorders or myasthenia. I'm not going to be talking about the first two today, though they're really fascinating topics. Transient neonatal myasthenia involves transplacental antibody transfer from mother to child, and I won't be getting into that today. Congenital myasthenic syndromes are genetic disorders of the neuromuscular junction, so in those channels and other genes that are important for neuromuscular junction transmission. And then autoimmune myasthenia gravis is what I'll be focusing on today. This is not a super rare disease overall, about 1 in 17,000 across the US population, but only about 10% of this population has onset in the pediatric years. So it is a fairly rare disease in the pediatric population. So the symptoms we see with myasthenia gravis, ocular weakness is really the number one muscle group. Anytime I see a patient with droopy eyelids, double vision, trouble squeezing their eyes closed, neuromuscular junction disorders and myasthenia kind of rise to the top of the list, but you can also see weakness in the bulbar muscles with chewing, swallowing, speaking. Respiratory muscles, that is the most feared complication, is respiratory failure, and this can be exacerbated by exercise or lying down. Limb weakness tends to be in the hip and shoulder girdles and the finger muscles, and then this key feature of fatigability, which we don't really see in other neurological disorders to this extent, where the more you use a muscle, the weaker it gets. And you can actually do this in the clinic room by exercising a patient, and you may get a 4 out of 5 before they exercise, and then a 3 out of 5 after 10 or 20 seconds of exercise. So how do we diagnose myasthenia gravis? The immediate tests that we can often do in the office on the same day that we first meet a patient are the electrodiagnostic tests. And in particular here, we do repetitive nerve stimulation, which is a type of nerve conduction study. So up here, you can see this is a median nerve conduction study recording from the abductor pollicis brevis. And what we do when looking for a neuromuscular junction disorder is we give 10 pulses at 2 hertz, and we look for what the amplitudes are. And this is a pretty uncomfortable test, and most kids don't tolerate doing more than about 3 nerves. And so that accounts for some of the reduced sensitivity, particularly in the pediatric population. And then single fiber EMG is something we actually don't do in our pediatric hospital here. I have to send these patients over to an adult specialist who does it either here at UC Davis or at UC Davis. And this is a more sensitive test, but really tough to kid because there's needles sticking one of the about 30 to 45 minutes. And it's not completely specific for MG test because it can be positive in other myopathies and mitochondrial disease, for example. So the other way we test for myasthenia is with antibodies, and this gets part of the mechanism for MG, or pathogenic antibodies that target epitopes in the postsynaptic muscle membrane. The most prevalent of these is the acetylcholine receptor, and then there are some less prevalent antibodies, MuSK and LRP4. And so in the adult population, about 85% of patients will have some antibody positivity, but that still leaves about 10 to 15% who are seronegative, and that is a larger proportion in the pediatric population. The numbers kind of vary, but it's definitely more than in the adult population. And so how do these antibodies work at the muscle? So in a normal muscle, there's acetylcholine released at the motor neuron presynaptic membrane, and that acetylcholine binds to these acetylcholine receptors, the thick red ones here. And that in turn generates an action potential with the sodium channels down here in the synaptic clefts. And that electrical activity together generates an end plate potential that leads to muscle contraction. On the other hand, when you have damage of the postsynaptic membrane by these pathogenic antibodies, you get a reduced receptor density for acetylcholine receptors and reduced density of sodium channels, and also a simplification of those that surface area of the postsynaptic membrane. And that results in a smaller end plate potential and the vulnerability to muscle fatiguing in the case of myasthenia. And so back to our patient, this 7-year-old, weakness at the end of the day. Exam findings are pretty typical for myasthenia gravis, and We were able to do the nerve conduction study the same day. She did have this decremental response in one nerve. We were only able to do two nerves, and it took a lot of bargaining because, again, this is an uncomfortable procedure. But we got the diagnosis with that one abnormal muscle nerve pair. And then her antibodies were negative, so we diagnosed her with seronegative myasthenia gravis. And she had a good initial response to pyridostigmine, which is an acetylcholinesterase inhibitor, so allows the acetylcholine to last longer in the synaptic cleft and activate those receptors. We did have to add on some immunosuppression with IVIG and steroids, and these initially worked, but then things worsened, and I'll get back to her later. So after I met that patient, I started to get more referrals for patients with fatigable weakness. Some of them had seropositive myasthenia gravis, pretty straightforward to diagnose. But I started to meet more of these patients with autoinflammatory syndromes like that first one. And most of them ended up being seronegative. And most of them had abnormal nerve conduction studies, but some did not, including this 9-year-old boy that I outline at the bottom here, who'd had years of rashes and asthma and mouth sores, migraines, a kind of unique pain syndrome with erythromelalgia, gastroparesis. And then he suddenly developed ptosis and double vision, fatigable weakness over a few months period. And they live in the mountains, and he went from being very active with mountain biking and skiing to not being able to do those things at all. And when I saw him, he had an exam that looked very typical for a patient with myasthenia gravis, with weakness in the ocular muscles, neck flexors, shoulder and hip girdles and fingers. But his repetitive nerve stimulation was normal and his antibodies were negative. So I was scratching my head a little bit about what to do for him, but figured I would try him on the acetylcholinesterase inhibitor pyridostigmine, which is our first line treatment for myasthenia. And this also kind of led me to wonder about whether I could even diagnose this patient with myasthenia. And so for purpose of clinical trials, such as this one from France using rituximab, the pediatric diagnosis of myasthenia gravis depends on the presence of fatigable weakness, and then one of the following, either positive antibodies, abnormal electrodiagnostics, or a clinical response to acetylcholinesterase inhibitor pyridostigmine. So this patient, having a response of his symptoms, particularly his ptosis got better with pyridostigmine, could be diagnosed with myasthenia gravis based on these criteria. And then over the years, we've now accumulated over the past 7 years or so, 24 patients with seronegative myasthenia gravis. And don't worry about all the information in the table. This is just to show that we've kind of cataloged the symptoms and medications that they're on and response to treatments. These patients all pretty much line up with typical symptoms of seropositive myasthenia gravis patients. They have fluctuating weakness, they have ptosis, they have response to pyridostigmine. I've tested them genetically for those congenital myasthenic syndromes that I mentioned earlier in the talk, just to make sure they don't have a genetic type of myasthenia. And overall, these seronegative patients fall into several groups. One is ocular myasthenia, which is a very well-known seronegative group. A number of them have pain syndromes, which was a bit surprising because pain is not usually a part of myasthenia, but I found a number of the children experience muscle fatigue as painful or reported as painful, and that pain may improve with treatment of their myasthenia. And then the largest group is these patients with autoinflammatory syndromes, and I've mentioned autoinflammatory syndromes a few times, so I want to just define them here. So these are disorders of the innate immune system presumed to be genetic. They encompass the periodic fever syndromes, which you're all probably familiar with, but are larger than that subgroup. And the symptoms can look a lot like infection or autoimmune disease with fevers and pains in the muscles and joints, abdominal pain, rashes, and even some more unusual symptoms like aseptic meningitis and sensory neural hearing loss. And inflammatory markers are often elevated during flares and may go back to normal in between. And the treatments are things like steroids and IL-1 inhibitors like anakinra, TNF-alpha inhibitors, and colchicine. So among these patients with autoinflammatory syndromes and seronegative myasthenia gravis, we actually have 4 sets of siblings, including these two sisters. That includes a 7-year-old I mentioned earlier with relapsing polychondritis. They both have abnormal repetitive nerve stimulation. The 9-year-old I just mentioned, and a 17-year-old we saw more recently, who had quite a dramatic development of fatigability over a few months that led to respiratory failure. And she also had negative repetitive nerve stimulation. So all these patients respond as you would expect for a seropositive myasthenia patient to steroids and IVIG, but often their responses were incomplete. We had to go to plasma exchange in some, but of course that's not a great long-term outpatient management strategy. And so these patients have ended up often being refractory and requiring off-label monoclonal antibody therapies that I'll get to in a moment. So how do we manage these refractory myasthenia gravis cases? So across the board, most of our myasthenia patients, especially the seropositive ones, do respond well to IVIG and steroids. Of course, steroids come with a ton of undesirable side effects, and there are oral steroid-sparing agents, which unfortunately take a really long time to work, from 6 to 9 months. And so they're not a great option for our more symptomatic patients. And so we often have to go to intermittent IVIG or even intermittent plasma exchange. But both of these are really time-consuming, uncomfortable. Plasma exchange, especially over the long term, will require an indwelling catheter, which is not ideal. And there's thymectomy as well, which is well established in the adult seropositive myasthenia population, but there really is not consensus around how valuable thymectomy is for seronegative patients or for children in general. And so that's kind of on a case-by-case basis. So the immune mechanisms that we're targeting in MG are may look familiar to some of the other immune diseases that you all manage, and can encompass B-cell targeting agents like rituximab and obinutuzumab, plasma cell targeting agents like daratumumab, targeting terminal complement with eculizumab, which acts at sort of the final stage of that antibody-mediated toxicity at the postsynaptic membrane, where you get the membrane attack complex generated by complement activation. And then there's also a new class of fetal FcRn receptor inhibitors. The FcRn helps to stabilize antibodies, and so by blocking it, you destabilize and shorten the half-life of antibodies, including the pathogenic ones. And so a couple of these are FDA approved now for pediatric myasthenia, although those approvals happened just in the last couple of years, and so we're having to manage some of these patients pre-approval. There's some class 3 evidence for rituximab, and the advantage of these monoclonal antibodies is really they're more targeted and they require shorter and less frequent infusions than IVIG. So coming back to that 9-year-old patient, he had a great response to rituximab, got back to skiing and mountain biking, had about a 6-month remission, and then the rituximab kind of stopped working as well. His B cells were coming back a lot faster than we expect with rituximab, and we thought that he might be generating anti-rituximab antibodies, and he ended up having his worst flare-up in the setting of this rituximab decreased efficacy, needed some plasma exchange, made a great recovery with the plasma exchange, and we started him then on obinutuzumab, and this is also an anti-CD20 antibody like rituximab, but it is humanized and does not cross-react with those anti-rituximab antibodies. And he's now had great disease stabilization for almost 2 years on obinutuzumab. And so he's an example of a patient who's very responsive to B-cell inhibitors. And so all in all, we've tried basically every one of these different mechanisms with variable success, including the B-cell inhibitors, plasma cell inhibitors, FcRn inhibitors, and complement blockers. And so coming back to our 7-year-old patient from the beginning, she's ended up being my most complicated patient with myasthenia. I think many of you have cared for her in the teacup and the PICU. And she started off with eculizumab and IVIG doing great. Then she worsened when insurance stopped covering her eculizumab for a few months. We had to give her plasma exchange. Rituximab had no effect. And then we've been able to space out her plasma exchange a bit with the combination of a plasma cell and a B-cell inhibitor, but she's still requiring plasma exchange. We've more recently added in another complement inhibitor, ravulizumab, and are hoping to make a dent in her symptoms. But she demonstrates one of the challenges of managing these patients with autoinflammatory syndromes and myasthenia is that she has this constant level of ongoing inflammation from her autoinflammatory syndrome that kind of drives the myasthenia, and infections in particular really send her immune system into overdrive and lead to respiratory exacerbations. And so, we may have to look towards more aggressive strategies like CAR T cells and potentially bone marrow transplant for our super complicated patients. So just to summarize this part of the talk, I've presented to you a cohort of children with autoinflammatory syndromes and myasthenia that hasn't been described in the literature before, and find that these patients have very similar symptoms to seropositive patients and similar responses to treatment, although are often refractory, which we think may be due to the underlying immune system dysfunction that they have. And so we have ongoing work, and I'm working closely with Alice Chan in immunology on trying to identify any cytokine signatures, doing genetic testing to see if we can identify the underlying parts of the immune system that are dysfunctioning in these patients. We're working with the Wilson and Pleasure labs to see if we can identify novel antibodies, because all of these patients don't seem to be positive for those three that we can test for clinically. And then we're also working on getting more access to single fiber EMG in the pediatric population so that we can make accurate diagnoses more efficiently. So I'm going to switch gears now to gene therapy, but we're not going to be completely leaving the immunosuppression realm, as you'll see in a moment. And so for the purposes of our talk today, gene therapy, I'm going to be referring to adeno-associated virus, or AAV gene therapies. There are some very interesting developments in treatment of neurological diseases with hematopoietic lentiviral-based gene therapies for adrenoleukodystrophy and metachromatic leukodystrophy, but those are really separate topics. And AAV vectors are the main ones that are being used in neurological diseases these days. And so AAV viruses basically are a protein capsid in which you can package your gene of interest and promoter and some other genetic elements. The AAV capsid will deliver the genetic material to your target cells, and that the genetic material can get to the nucleus where it persists as a circular DNA or episome that can be transcribed and translated into the protein that you're trying to get expressed in that tissue. And so these are non-replicating viruses. The body isn't going to generate more of them over time, but they do generate an immune response, which, as you'll see a little bit later, is the source of most of the complications we see with gene therapy. And the first disease I'm going to talk about with a gene therapy treatment is spinal muscular atrophy. And as you'll see, the treatments for SMA really set the bar very high for gene therapy. And for those of you who haven't seen a patient with SMA, you're probably less likely to have seen one in the last decade or so because of these treatments. But when I was a resident about 12 years ago, this was really one of the worst diagnoses you could make, because these babies would be born looking normal, bright-eyed, very interactive, and then would start to become hypotonic and weak in the first few months of life. You'd make the diagnosis, and then it was basically a palliative care discussion, because we knew that inevitably these children were going to have progressive hypotonia, muscle weakness, and ultimately respiratory failure, which led to death in the first year or two for the vast majority of these patients. And you can see that in the natural history survival curve there, where by 20 months of age, about 80% of these children have either died or required permanent ventilation. And this is a disorder of the anterior horn cells in the spinal cord, the motor neurons. So you can think of it kind of as an ALS for young children. And the most common form that we see is type 1, which presents before 6 months of age. These children never sit independently, and the vast majority die by 2 years of age. But there is a spectrum of SMA, with the most severe type 0 starting in utero, and the mildest form type 4 starting in adulthood. The genetics of SMA are unique in that on the long arm of chromosome 5, there are two highly homologous genes, SMN1 and SMN2. And the disease SMA is caused by loss of both copies of SMN1, but we all have a variable number of copies of SMN2, usually ranging from 1 to 4. And it's the number of SMN2 copies that in large part drive the severity of the phenotype, whether you're a type 0, 1, or 3, or 4. And what's different about SMN2 compared to SMN1 is that there's a point mutation in this exon 7 here that leads to it being spliced out of the transcript about 90% of the time. And when it is spliced out, you get unstable protein that gets degraded. And so this SMN2 gene is really only about 10% efficient at generating full-length SMN protein that you need for your motor neurons to function. And so the genetics could lead you towards two possible mechanisms to treat this disease. So one would be, can we get more exon 7 incorporated into these transcripts so we shift the balance towards more stable full-length protein? And that's exactly what's been done with two drugs that are FDA approved now. There's an antisense oligonucleotide called nusinersen that enhances exon 7 inclusion. And then there's a small molecule splicing modifier, risdiplam, that increases exon 7 incorporation as well. I'm not going to talk about those further today, but they are very effective treatments and are part of the treatment landscape that has really turned this from a fatal disease into a highly treatable disease. What I am going to talk more about today is the gene therapy approach, which is much simpler, where you just package this SMN1 gene into an AAV vector and deliver it intravenously, and it gets to the motor neurons and has some pretty dramatic effects, which I will now show to you. So the first clinical trial for SMA was done in symptomatic infants with type 1 SMA. So these were kids who'd already shown signs of hypotonia and weakness within the first 6 or so months of life. They were given this AAV9 subtype vector carrying the SMN1 gene. And just as background, all of these children had to be negative for anti-AAV antibodies. You couldn't get into the trial, and you can't get the treatment post-approval if you have a high titer of anti-AAV antibodies, which most infants don't, but as you get older, the likelihood of having those antibodies increases. And all these children were treated with prophylactic corticosteroids starting a day before the gene therapy and continuing for several months. And that's to protect against some of the hyper immune activation side effects that can happen. And I'll talk about those more in a second. But what you can see here with the clinical trial data is that survival curve was really devastating in the natural history cohort shown here in blue. But when these infants were treated with gene therapy, almost none of them had died or required permanent ventilation by 15 months of age. So really dramatic alteration compared to the natural history. And if we look at their motor function, which is done with this CHOP Intend early motor skills score. So there's typically a ceiling of 40 on this scale for children with type 1 SMA. And as you can see, almost all of the children in the trial are exceeding that level of 40. So we're getting unprecedented motor outcome improvement post-gene therapy in symptomatic infants. And with this data in mind, you might think, could we do even better by going to the pre-symptomatic population? Unfortunately, there were some programs that were allowing for screening at birth, so we could capture some of these children before they became symptomatic in the first few months of life. And the results when infants were treated in the pre-symptomatic period with this same gene therapy were even more dramatic. You can see clearly now almost all of these children are showing really robust CHOP Intend scores, and some of them are even maxing out the scale at 64. And then if we look at the Bayley motor outcomes, which are the shaded gray areas for age here, you can see that out to over 2 years, all of the infants with 3 copies of SMN2 have normal motor outcomes. And for those with only 2 copies of SMN2, the majority still have normal motor outcomes, and even those that don't are showing great progress in their motor skills. So this gene therapy really has been transformative for the field, and I think is the most incredible medical advance that I've seen in in my time as a pediatric neurologist. And so based on the data I showed you, the gene therapy onasemnogene abeparvovec, also known as Zolgensma, was approved for under 2-year-olds, delivered intravenously. And then just in the past few months, an intrathecal version has been approved for children over 2 years of age and adults. And so this is truly a therapy that I wouldn't quite say curative yet, because we don't know what the outcomes are going to look like 10, 20 years down the line, but at least in terms of the first few years of life, it is normalizing motor development, and it is truly life-saving for these patients. And you can argue about the costs of medications, but I think for a disease this terrible, $2 million given in the pre-symptomatic period is worth all of those saved healthcare costs and all of the devastation that this disease used to cause to families after diagnosis. But these gene therapies do come with risks as well. And so there are some that we commonly see, like elevated transaminases. This typically happens in the first week or so after the gene therapy, and then can happen again in the second month. These elevations of transaminases are usually steroid responsive, but in rare cases have escalated to the point of liver failure and death in a couple children about 5 to 6 weeks post gene therapy. We sometimes see troponin elevations, which fortunately seem to be asymptomatic in most cases with no changes on echo or EKG. And then there have been case reports of HLH and thrombotic microangiopathy as well following SMA gene therapy, but fortunately none of these have been fatal. So a more common disease that we see in our pediatric neuromuscular clinic is Duchenne muscular dystrophy. This is an X-linked disorder that affects about 1 in 3,500 boys. Females are typically unaffected in childhood, though the mothers may develop the cardiomyopathy later in life. And DMD is caused by out-of-frame or truncation mutations in the dystrophin or DMD gene. And there's a milder type of muscular dystrophy called Becker muscular dystrophy that is associated with in-frame deletions of exons and missense mutations. And DMD is not just a skeletal muscle disease, it is also a cardiac muscle disease. And both the skeletal muscle disease and cardiac disease are progressive and lead to reduced lifespan. There's also a perhaps underappreciated cognitive phenotype for Duchenne muscular dystrophy. About a third of the boys are impacted by ADHD, autism spectrum disorder, and learning difficulties. And these are non-progressive, so more of a neurodevelopmental disorder. And the natural history of DMD is that at birth, most children appear asymptomatic, but if you measure a creatine kinase right around the time of birth, it will be elevated. So that is forming the basis for some newborn screening programs that are being rolled out in a few states. But in terms of symptoms, these children appear mostly normal. In the first couple of years of life, there's often some mild developmental delays. A lot of the children are late to walk, may have some speech delays, but it's really not until 3 to 5 years of age that they're usually brought to medical attention when they're going to school and somebody starts noticing that these kids are the slowest runners, they're falling more, they're having trouble getting up off the ground. And so from the time the disease is diagnosed, around that 3, 4, 5-year-old age range, these children do continue to get a little bit stronger and they plateau around 6 or 7 years of age, and then strength starts to decline inexorably. And by 10 to 12 years of age, the majority are non-ambulatory. And it's in the teenage years that we start to see the cardiomyopathy progress. We start to see a need for nocturnal non-invasive ventilation. And then the third decade is really where we see mortality from cardiac and respiratory disease. The gene therapy approaches for DMD are similar to what I talked about for SMA, but with some key differences. The main one being that the DMD gene is the largest gene in the human genome and is too big to package into an AAV vector. And so nature kind of helped us out here in that there are some patients with Becker muscular dystrophy who have huge deletions of more than a dozen exons in this gene, but are still walking into their 60s. And so that taught us that you can actually miniaturize the dystrophin gene and still retain most of its key functions. And so that's what's been done for all of these gene therapy programs. The only one that's FDA approved is the one on top here that I'll discuss in a little more detail. They all use AAV vectors, some use different promoters, and then all of them have slightly different exons that they've included and excluded, but the idea is the same, to restore dystrophin function to skeletal muscle and heart. So the first approved gene therapy for DMD is delandistrogene moxeparvovec, also known as Elevidys, and this was approved based on a clinical trial looking at 4 to 7-year-old boys. And the data were initially a little disappointing. They used the North Star Ambulatory Assessment, or NSAA, as their primary endpoint. And you can see that in the overall population, the purple treated patients compared to the gold natural history, there was no statistically significant difference after a year. If you broke these into 4 to 5-year-olds, there was a statistically significant difference, but not in the 6 to 7-year-olds. And so this led to the approval for only 4 to 5-year-old patients initially. This was only a 52-week trial. As we followed the first 4 patients treated over more time, over 4 years, you can see that there is a bit more of a spread in the NSAA scores between the treated patients and the natural history. But I think overall, especially compared to SMA, these data were a little bit underwhelming. And so the timeline of approval for delandistrogene moxeparvovec is that it was approved for 4 to 5-year-old boys in June 2023. And then the company brought more data to the FDA, as often happens for older boys, non-ambulatory boys. And they actually argued to the FDA that some secondary outcome measures, like the time it takes to get up from the floor, were actually more accurate measures of the gene therapy's efficacy in that first year or two out. And the FDA was convinced, and they granted a full approval for ambulatory boys of all ages. And then they gave an accelerated approval for non-ambulatory boys and men, meaning that the company had to continue their clinical trials, continue collecting data, report back to the FDA, and the FDA reserved the right to rescind that approval if the data didn't pan out. Later in the summer of 2024, Pfizer, which was another company doing a gene therapy for Duchenne muscular dystrophy, failed to meet its primary endpoints, and there was a death in the trial, and the program ended up shutting down. So that was an important lesson, that waiting for the next thing to come along is not always a good bet. Sometimes it won't work at all. And so we're left with just one gene therapy program approved. And then just this past summer, the first 2 deaths post-gene therapy were reported in 2 16-year-old non-ambulatory boys from acute liver failure about 7 weeks post-gene therapy. And this initially led to a complete pause in all shipments of the gene therapy, and then eventually treatment was allowed to resume, but only for the ambulatory population. So the non-ambulatory patients currently cannot get gene therapy outside of a clinical trial. So as you can see, the story is overall more complicated for DMD than for SMA. Anytime you see a drug approved based on secondary endpoints rather than the primary endpoints, it makes you a little suspicious and less convinced that the people doing the trial kind of had a well-designed trial. There's also concerns about the durability of this gene therapy. Muscles are not the same as motor neurons. The motor neurons that you're born with are the motor neurons you have when you're 10, 20, 30, 40 years old. Those don't turn over, but muscle does. So the muscle cells you're born with are going to degenerate and regenerate and turn over many times. And so we expect that a gene therapy delivered to muscle tissue is not going to be durable for life and may have an expiration date after 5, 10 years. We're not really sure yet. We've had the deaths that I mentioned in the Pfizer and the delandistrogene studies. And then there was an unfortunate N of 1 trial using a CRISPR-based therapeutic for a 27-year-old young man with DMD. And he unfortunately had a severe inflammatory response to the gene therapy and died within a week of getting this CRISPR-based treatment. And so overall, we have a medication that appears to help with ambulation, at least in some patients, but really unclear benefits for what we care about most in the long term, which is respiratory function, cardiac function, the brain disease. And even with all this uncertainty, it's an incredibly expensive drug at $3 million per single dose. So I want to talk more about some of the adverse effects with gene therapies. So I've mentioned the deaths in the Sarepta gene therapy, the Pfizer gene therapy, the CRISPR agent. There's also a very promising clinical trial for a different muscle disease, MTM1 or myotubular myopathy. And they're seeing really dramatic improvements in these boys. It's another X-linked disorder. People were coming off of their ventilators. Kids were starting to walk, but there were 4 deaths from liver disease. And it turned out that the gene therapy was kind of unmasking a cholestatic liver disease in these patients that hadn't really been appreciated beforehand. And so all this goes to show that the complications of gene therapy are not to be underestimated. They can affect multiple tissues. You can see these systemic inflammatory responses like thrombotic microangiopathy and HLH. You can see heart inflammation, liver inflammation, and even dorsal root ganglion injury in some cases. And so just as an example from one of our clinical trials, we had a 22-month-old who received IV gene therapy. 4 days afterwards, she developed thrombocytopenia, rising LDH, and anemia. And by day 7, her platelets had dropped below 30, the anemia was worsening, and she had a rising creatinine and these other ominous markers of elevated SC5b9 or terminal complement, dropping C3 and C4 complement. She had fragmented cells or schistocytes on her peripheral smear, was becoming hypertensive with proteinuria and hematuria. And so all of these symptoms were pointing towards a diagnosis of thrombotic microangiopathy. She required multiple platelet and packed red cell transfusions, and then we started her on eculizumab at Q72 hours. So you may recognize eculizumab from the myasthenia part of the talk. This is a terminal complement inhibitor that has really become the new way to manage thrombotic microangiopathy. But eculizumab wasn't enough for this patient, nor was rituximab, and she ultimately had to start on dialysis, and dialysis and eculizumab were continued for 4.5 weeks until she started to make urine again, and her terminal complement levels dropped to normal. And so this was a near fatal event that I'm very grateful to our BMT colleagues for helping us manage, as well as our nephrologists over in Oakland who really helped this child get through a scary episode. And so we've learned a lot from this and several other cases of TMA that we had to deal with last year. Steroids are usually not enough to prevent TMA. And once it starts, you have to treat aggressively with eculizumab as often as every 48 hours. And just as context, in myasthenia, we give it every 14 days. So this is a very aggressive complement suppression strategy. Rituximab can be used post-treatment to prevent the antibody response that we think drives that complement to get activated and cause TMA. And then dialysis may be used in some cases. And then a number of gene therapy trials are increasingly using prophylactic regimens to try to prevent TMA from happening in the first place. And these are typically steroids, rituximab, and sirolimus, or steroids, eculizumab, and sirolimus. And so these are just some of the serious adverse events that we've seen in our gene therapy trials over the past couple of years. And the treatments for them, you'll see overlap a lot with our treatments for myasthenia gravis. And so I really was able to learn a lot from treating patients with myasthenia and bring that to our gene therapy patients. And in turn, I've become a lot more comfortable with eculizumab and complement suppression, and that has helped me treat some of our more complicated myasthenia gravis patients as well. And so I've talked about neuromuscular diseases. What about brain diseases? these are 6 different brain diseases that we have clinical trials for at UCSF. The top one is run by Nalan Gupta here at Mission Bay, and the other 5 are we're doing over in Oakland with our research team. And I'm going to focus on one of these today, which is Canavan disease. So Canavan disease is a neurodegenerative disorder. It's recessive and is caused by loss of both copies of the ASPA or aspartoacylase gene. This is an enzyme that's very important for oligodendrocyte function. Those are the myelinating cells of the brain. And when NAA builds up, because it can't be broken down by this enzyme into acetate and aspartate, it prevents normal white matter development and causes destruction of any white matter that is formed. And the clinical manifestations of this disease are quite devastating. These children become macrocephalic, have trouble holding up their heads. They become progressively hypotonic, have cortical visual impairment. They eventually become very stiff and spastic, develop seizures, and usually die by the end of the first decade of life. And so we're a part of both the natural history study as well as the gene therapy trial. So for the gene therapy trial, we treated infants under 30 months of age, and the first 8 patients received a lower dose, and then all of the subsequent 11 patients have received a higher dose. All of these children had to be negative for those AAV antibodies that I mentioned earlier, and they are treated with corticosteroids starting on day -1 and continued for 3 months after the gene therapy. So from the natural history study, in Canavan disease, if we look at motor function with the GMFM-88, which is a gross motor developmental scale, these children start at really low levels and they stay at really low levels. So it's not so much a disorder where there's normal development for a while and then regression. These children really just never make much motor developmental progress. By contrast, when we looked at the GMFM scores in the first 11 patients that we treated with this gene therapy, we saw this steady rise in GMFM scores that clearly deviated from the natural history of this study. And we also have a biomarker that we can follow in Canavan disease, the urine and acetyl aspartate. And you can see that within the first month of therapy, these NAA levels are dropping. And in black are the low dose patients, and in red are the first 3 high dose patients. And you can see the high dose patients drop even more quickly and to lower levels than the low dose patients. So this is a good piece of evidence that our gene therapy was hitting the target and that enzymatic activity was being restored. And then if we look at the brain MRIs, so this is the MRI of a 10-month-old, a T2 MRI, and this is very abnormal. All of this bright stuff you see here is abnormal white matter that you should not see in a 10-month-old. This should all be dark, kind of black. And after 18 months post gene therapy, you can see that there's none of this bright signal anymore. And this is fairly normal appearing white matter now. And if we want to look a little more in detail at white matter development, we can use a T1 sequence here. And at 10 months of age, there's really no myelin. These dark areas here should have started to myelinate in a approximately 1-year-old infant, but you can only see some myelin at the corpus callosum and the pons here. By contrast, at 18 months post-treatment, you can see that there's myelin now forming in the frontal lobes all the way to the occipital lobes here, as well as in the brainstem, cerebellum, and spinal cord. And here's just a little bit more detailed look at that new white matter formation, which just does not happen without treatment of this disease. And then, of course, what we care most about is how is the child doing in terms of development. And so this is one family that gave me permission to share some videos. So this is pre-dosing. You can see this infant at 10 months old is not able to lift her head up off of the ground, can barely lift her arms and legs up as well, can't really do much to interact with this toy. And then 5 months post gene therapy, she's achieved tripod sitting, and now she's further out and can sit completely independently and is starting to take some steps facilitated by her dad there. And then she's also acquired a new skill of being able to take a fork loaded with food and feed herself. And these are things, as you can see from the GMFM data that I showed earlier, just do not happen in the natural history of this disease. And so the takeaways from this part of the talk are, I hope you saw with SMA that gene therapy can be truly transformative and life-saving when applied to the right disease, like SMA. More complicated story for DMD, and we still have a long way to go for treating that patient population. The gene therapy that's currently approved leaves a lot to be desired, both in terms of safety and efficacy. The toxicities of gene therapy can be life-threatening and really do require a multidisciplinary team. And I am so grateful to work in a place where we can collaborate with our BMT, hemonc, immunology, nephrology, endocrinology colleagues to get everyone's input in managing these patients and helping them weather some pretty bad storms that we had in our trial patients last year. And then just wanted to highlight too that crosstalk between the treatment of myasthenia and treatment of complications of gene therapy, and how both of those kind of inform each other, and it's really helped me to come from the myasthenia space and be able to take what I learned from gene therapy back to my complex myasthenia patients. And of course, there are still a lot of unmet needs in the gene therapy space. We need more targeted vectors that don't cause all these side effects from organs that we're not meaning to target, like the liver. And we could use lower doses if we had more targeted gene therapies. We need better immunosuppression regimens so that we can get away from these long courses of steroids that cause side effects and these long courses of B-cell suppression with rituximab. And then we need ways to redose patients, because after you get an AAV gene therapy, your immune system generates very high antibody titers. And if you try to give a second dose, your immune system will just destroy it. And so we need strategies both for individuals who are positive for AAV antibodies and for those who need to be redosed, which I expect any patient with DMD or another muscle disease will need repeated doses of gene therapy throughout their lifetime. So I want to thank all of our patients and families who have participated in our clinical trials. Alice Chan in particular in immunology has worked closely with me on both parts of this spectrum of autoinflammatory MG and gene therapy complications. And then want to thank, of course, my research team over at Oakland, my colleagues in the neuromuscular clinic here, and you all for your attention. I'll be happy to take some questions.
Hey, we have a microphone today, so I can carry it around if there's any questions. We have a couple minutes. Nothing yet on Zoom, so, and thanks everyone for bearing with us.
Hi, thanks for that really interesting talk, and it's great to see the progress that's been made just over the last 5 to 10 years in this field. My question is related to the side effects that you're seeing. Is this related to the serotypes of the AAVs and the tissue trophism that's a problem, or is it a generalized immune response to the viral infection in these hosts?
It seems to be particular to AAV vectors that all of them seem to hit the liver pretty hard. There are subtypes that are better at getting into certain tissues, like the brain and the spinal cord with AAV9, but that better specificity for the brain doesn't eliminate the off-target effects. And so the liver inflammation, the cardiac toxicity are things that have been seen with different types of AAV vectors and seem to just be due to the fact that it's really hard to make the liver not sop up a lot of the gene therapy. And that happens even when we give these into the brain intrathecally by lumbar puncture. If one of our neurosurgeons puts it into the ventricle, it still crosses that blood-brain barrier and we can still see liver toxicity. So we really need to find a way to make these vectors so that the liver can ignore them. And so we still have a ways to go with that.
I have a question. Thanks for this really interesting talk. Question about the cost. First of all, I wouldn't want to be the nurse or the doctor that accidentally drops the syringe because, whoops. But I always understand and don't understand. I mean, I hear why the cost has to be this high, but what is actually the path to lowering the cost? Because I assume that the high cost actually does not make this accessible to all patients with the disease. So are there pathways, ways in which your clinical research organization nationally thinks about this?
Yeah, the costs are always a shifting landscape because the cost may be announced, but then certain payers will make a deal with the manufacturer and it'll actually be a lower cost. And so was involved in discussions with CCS when the DMD gene therapy was rolled out, about exactly what part of the patient population they should cover. Because when the label was expanded from 4 to 5-year-olds to everyone, basically, CCS was understandably freaking out. Like, how are we going to pay for patients from 4 to 25 who want this gene therapy? Is there even data? Is it safe? Should it cost the same for a 4-year-old and a 20-year-old? And I think I have a strong opinion on that, but that's not how drugs are priced in our country. And really, the pricing of a drug has nothing to do with the efficacy. It is set by the manufacturer, and the FDA doesn't weigh in on that. And so I think that's just a case where we need to overhaul parts of how drugs are priced. And of course, we need innovation. We need companies to recoup the costs of making these medications. Many of these companies have failed clinical trials, and so they're trying to recoup the costs of several trials with one drug that gets approved. So, that's just kind of how the system works. But I think there may be some examples from other diseases. Like I've heard with the treatment of hepatitis C that a lot of the payers got together and basically said, we can't pay for all of these patients right now at this cost, and they were able to negotiate a lower price. And so I think that kind of pressure is needed so that, I would personally like to see a sliding scale of cost proportional to what the study data show. If you have a trial on 4 to 7-year-olds, then you can charge your target price for that subgroup, but not for patients that fall way outside of the range where we really don't know how well this drug is going to work. But nobody asked me, and so
I did.
Yeah. Yeah.
I think we're at time. Yes.
Okay.
Thank you so much. And,
All right.
and
Thanks,
sorry
everyone.
for the technology issue.
Oh, no worries.